Merhabalar sevgili katılımcılar, hoş geldiniz. Bir başka uluslararası webinarımıza. Bugün sepsiste kişiselleştirilmiş immünoterapiden ve daha birçok şeyden bahsedeceğiz. Çok değerli bir konuğumuz var. Takdim etmesi için ve başlatması için webinarı sözü Emine Alp Meşe'ye bırakıyorum. Buyurun hocam.
Teşekkür ediyorum Aslıhan. Çok sağ olun.
Özür
Bugün
diliyorum.
çok değerli.
Söylemeyi unutmayayım. Çok özür diliyorum hocam. Dinlemek isteyenlere altyazı seçeneğimiz var. Aşağıda CC altyazıları göster kısmında İngilizce konuşma dili, altyazı dili Türkçe olarak eğer dilerseniz altyazılı olarak da seyredebilirsiniz. Bir miktar yardımcı olabilir. Teşekkür ederim. Çok özür diliyorum hocam.
Yok, çok teşekkür ediyorum. Bugün çok değerli bir konuğumuz var. Evangelos Giamarellos-Bourboulis. Thank you very much, Giamarellos-Bourboulis. It's our great pleasure to host you in our webinar. I would like to introduce him. He is Professor of Internal Medicine and Infectious Diseases at the Medical School of the National and Kapodistrian University of Athens and Director of the Master Program of Infectious Diseases at the University of Athens. His main research contribution is immunomodulation in sepsis and in autoinflammatory disorders. He has approximately 600 publications in international peer-reviewed journals with more than 44,000 citations, and Ash index is 97. He has contributed in the development of clarithromycin for immunomodulatory treatment of severe infections and in the recognition of hidradenitis suppurativa as an autoinflammatory disorder and in the licensing adalimumab for the hidradenitis suppurativa. He's the current chairman of the European Sepsis Alliance and the current president of the Hellenic Society of Chemotherapy. His main achievement is the approval of anakinra for COVID-19 pneumonia in adults by the European Medicines Agency and the Food and Drug Administration through the phase 2 and 3 trials, SAVE and SAVE More, that he designed and conducted. Yes, thank you very much, Evangelos. It's our great privilege and our great pleasure. Floor is yours. Thank you so much.
Well, I do thank you very much for the opportunity of having me. And as a matter of fact, it's a long-standing friendship between us, and it's an honor for me working and collaborating with you, not only with you, but also with many colleagues from Turkey. And as a matter of fact, thank you also for giving me the opportunity to present to you something which, to the audience, something for which we have discussed for almost 2 years now, and for a new study which we want to launch here from Greece, and for which we do believe that it will be the opportunity to even strengthen our long-standing collaboration. So the talk today is whether immunotherapy, and actually precision immunotherapy for the critically ill, can be a myth or reality. And as a matter of fact, you know that always when it comes to infectious diseases, us who are working in this field, what we are doing is that we are borrowing knowledge from oncologists. You know, the only field so far where precision works is oncology, and actually in not all patients. The advantage of oncology is that they have tissue biopsies. They can trace the presence of oncogenes or overexpression of proteins, for instance, the anti-PD-1s for lung cancer or the anti-VEGF for lung cancer. And the same applies for colon cancer. But someone would say, okay, it's very important for oncology, but oncology gives you time. You can have the biopsy today, You may have the results in 1 week and then to start treatment. Can you wait that long for a patient who has acute illness? This is my conflict of interest disclosure for the presentation, and allow me to describe to you first 3 real cases of patients coming from our hospital. These patients were hospitalized for acute COVID-19. You see the mask, you see the precaution measures, you see that the patients, they are in the ventilation, and here is a male of 56 years old. He's hypertensive. He has a slight decrease of lymphocytes, very high CRP, very high ferritin. And then I asked my fellow, what is the treatment the patient receives? And the fellow replies, he gets the drug A, the drug B, the drug C, the drug D, exactly as it is in the guidelines. And of course, the fellow anticipates that you appraise him, that he knows so good the guidelines that he gave all the 4 drugs which are approved. And then you move to the next bed. And the next bed is older, and surprisingly, there are no comorbidities. And all of a sudden, you watch at the CRP and the fellow says, oh, probably I make a typo. Why there is a point between 9 and 8? It is indeed 39.8 or 398. But who cares? The patient gets the A, the B, the C, and the D, which are in the guidelines. And then finally, the last patient, full of comorbidities, heart failure, COPD, coronary heart disease, but impressive lymphocytopenia. CRP equal to the first one, but the ferritin is not as high as the first one. But who cares again? All what matters is that we adhere to the A, to the B, to the C, and the D of the guidelines. These patients, they cannot speak to us. Why? Because they're intubated. But they tell us, look, we are different than the others. We have different needs. And we don't know how to translate their needs and to give them the correct treatment. We give all of them the same drugs. But now allow me to present you what precision immunotherapy means and what is the vision. So there are 2 types of patients. All these are patients who are admitted from the emergencies. They're admitted for infection. Others patients, they're already hospitalized and they develop a hospital-acquired infection. And then all of a sudden, you use a biomarker. The biomarker could be a lab test, ferritin, CRP, or a phenotype. Many of you know that the group of Pittsburgh, they group patients based on their clinical characteristics. And just because the biomarker is unique for this specific patient, you give to the patient the unique treatment which fits the mechanism driving the disease. In other terms, what counts here to bring all of us back to the ages when we were young students, what counts is not anymore the clinical signs, but the pathophysiology. And you give treatment to meet the needs of the pathophysiology in order either to prevent the progression of the disease or to prevent death if the disease is already progressed. Allow me to show you an example coming from COVID-19. This is a patient who has a little bit of hypoxemia. He requires hospitalization. He has oxygen, but he has an increase of a biomarker which is called SUPOR. The biomarker tells you that because SUPOR is increased, the patient is under activation of the IL-1 pathway, and just because the biomarker is increased, you need to give a biological which blocks the biological activity of IL-1 alpha and IL-1 beta. And this biological is called anakinra. This appears a bit complex, but the idea is very simple. The patient has an infection, the biomarker is increased, and you give treatment. And exactly, we did that. And after 28 days, you may see what at the times of COVID-19 was called the WHO CPS, in other terms, a scale which suggests what is the condition of the health of the patient. In the gray zone are patients who are fully recovered and they are cured. In red are patients still hospitalized or dead. And you see that the patients who received this precision treatment, which was driven by the biomarker, they were allocated to a better state of health. But someone could say, is this precision treatment? How do I know that this is precision treatment? So look what all of us, we are doing in our everyday clinical life. We say, okay, the indication of treatment by the FDA and the EMA is that because the biomarker is increased, we need to give treatment, but this patient is pretty young, I will not give him treatment. Why? Because I have my prejudice. This patient has a lot of comorbidities, I will treat. And what we usually do, I will not give treatment because there are many days since the onset of pneumonia, and I don't believe that treatment will help. Now tell me how many of you who are listening to me now can deny that you are doing that on a daily basis? Probably very few of you. I've even been impacted and have this type of prejudice in my daily life. But if you look at the subgroups, if what counts is only the mechanism, and you give treatment towards a specific target, which you identify by the biomarker, the target is there, despite the age, the comorbidities, the sex, the time since disease onset, and it should work in all cases. And just exactly, it works in all cases. This is why we call that precision immunotherapy. And exactly for this, the European Medicines Agency and then the FDA approved on the grounds of the use of the biomarker anakinra for the treatment of COVID-19 pneumonia. And this is an example of precision immunotherapy for COVID-19. So when it comes to precision medicine, what we need to know is that therapeutics are guided by biomarkers. The biomarker should be informative of the degree of the implication of a certain disease pathway which drives outcome, and the available drug should modulate the pathway. Let's see what is happening in sepsis. Sepsis is called the organ dysfunction which is due to the dysregulated response of the host to an infection. Actually, when we come across an infectious disease and an infectious pathogen, the immune system is trying to find a balance between hyperinflammation and hypoinflammation. And the chase of the immune system for this balance is called immunohomeostasis. So some patients, they die very early. And they die very early because they are hyperinflammatory. And the pathway which leads to this early deterioration is called macrophage activation. Some other patients, they have a very weak immune response. And this immune response cannot recover. And these patients, they die, but they die later. And those who survive are those who they are at a daily transition between hyperinflammation and hypoinflammation, and in the very end, they manage to reach homeostasis. The question is whether this exists or not in medicine. You know, several times in the past, there were clinical trials where a monoclonal antibody, which is targeting a cytokine, was given as treatment to patients. All these trials, which they took place 30 years ago, all of them, they failed. And none of these drugs was approved. One of the trials used a monoclonal, the biological, which is targeting interleukin-1. And indeed, also this failed. As the time went on, the American Rheumatology Society, they taught to us that there is a condition which is called macrophage activation. The patients who are on macrophage activation, they suffer by liver dysfunction and coagulopathy. This knowledge was developed by the American School of Rheumatology almost 15 years ago. And then the need coming from the investigators of previous trials of anakinra was, if we try to analyze only for these patients who have both, not only both liver dysfunction and coagulopathy, could we improve their outcome? So this post hoc analysis showed in the dashed line, which you see at the bottom, that these patients who had both liver dysfunction and coagulopathy, and they were treated with placebo, they died by 65%. But if they were receiving treatment with anakinra, they died by only 35%. And this is the situation which is driven by IL-1. And actually, in these patients, activation of TLR4 by bacteria leads to high production of IL-1. Several times, this may even happen by viral infections. But the idea is that this IL-1 acts at the level of the tissue macrophage in an autoinflammatory way, and this drives further production of IL-1 beta, and this IL-1 beta stimulates the production of ferritin from the liver. So macrophage activation syndrome is a situation which we can recognize by extreme hyperferritinemia, but because IL-1 beta affects the liver, it leads to liver dysfunction, increase of aminotransferases, increase of bilirubin, and in parallel, decrease of fibrinogen, which leads to coagulopathy. And this is why hyperferritinemia, coagulopathy, and liver dysfunction are the main features of what we call macrophage activation-like syndrome. Actually, the American Society of Rheumatology, they have developed a score which they call HS score. The acronym stands for the score of hemophagocytosis. And you see how much higher is this score in the patients which they have the macrophage activation-like syndrome. How many are these of our patients? Somewhere around 4%. And there, you can see that these patients, they were all suffering by both liver dysfunction and coagulopathy. So in other terms, when you come across a patient with coagulopathy in the ICU, this should be an alert sign to look also for parallel signs of liver dysfunction, and then to ask yourself, did I come across a patient with macrophage activation-like syndrome? Finally, what is characteristic of these patients is that even if they suffer from ARDS, even if they suffer from acute kidney injury, even if they suffer by shock, the presence of macrophage activation in this patient is an independent driver for early death. What early death means? Death the first 10 days. Now allow me to, one of the main challenges which we faced was that they told us, okay, most of these findings are coming from Greece. And from the moment they come from a small country, they need to be validated from a big country. And we felt very happy when a few years ago, the group of Pittsburgh, they published their data on 1,300 patients, where they used, again, the presence of coagulopathy and liver dysfunction to recognize macrophage activation syndrome. They found this macrophage activation syndrome in 6% of their patients, and actually these patients, they died early, and the findings coming from Pittsburgh, they fully confirmed our findings. And as you may see here, they also confirmed that ferritin is the biomarker which gives the diagnosis. But as we said, these patients are 6%. Their characteristics is that they die early, but still they're only 6% of our sepsis cases. So the main question is, what is happening to the rest of our patients? These are 95 patients at septic shock. And in these patients, we isolated from their blood mononuclear cells. We started isolation the first 24 hours from start of vasopressors. We repeated that after 3, 7, and 10 days, and we stimulated the cells for the production of TNF. What you see is that day 1, the first 24 hours from start of vasopressors, the production of TNF which we get from the cells is minimal. But here in this graph, we have split our patients into 2 subgroups, those in blue and those in red. Those in blue are the patients which survive. Those in red are the patients who die. And you see that suddenly, those who are meant to survive, after 3 days, their cells, they wake up and they are still able for the production of TNF. And why is this so important? Because TNF recruits neutrophils, and neutrophils, they phagocytose bacteria. And you know very well from our daily clinical practice that the most difficult patient to treat is the patient who has defective neutrophils. So in other terms, although these patients with immunoparalysis, they do not suffer from neutropenia, they behave as if they suffer from neutropenia. So this immunoparalysis is the worst a patient may get. Actually, this corroborates very well the data which we have from the group of Richard Skoskis, already 15 years now, telling us that when patients with sepsis, they die because of immunoparalysis. As a matter of fact, the question were, how much often in patients with septic shock immunoparalysis is, and how often macrophage activation syndrome is. With that in mind, we ran a prospective trial, actually in patients with lung infections, and by using ferritin and HLA-DR, we classified our patients into macrophage activation syndrome and immunoparalysis. And look what we found. We found that immunologically, patients with septic shock, they can be classified into 3 strata. The worst outcome is for patients who they have high ferritin. They suffer from macrophage activation. These patients, as you see, they have a very poor outcome. The majority of them, 80% of them, they die by day 28. Then comes patients with immunoparalysis. They die less, but still they die a lot. And the best prognosis are the patients who lie immunologically somewhere intermediate. And this gives us a stimulus to say, okay, by using ferritin and HLA-DR, now we can classify prospectively patients with sepsis. And if ferritin is high, this means that the patients are suffering from macrophage activation syndrome. Macrophage activation syndrome is driven by interleukin-1. So let's treat these patients by giving them intravenously anakinra, which blocks IL-1. And in those with immunoparalysis, what is needed is to stimulate the immune response, to wake up the cells. And how can we do that? By giving them recombinant interferon gamma. After that, and after secure funding by the European Union, we framed a consortium by 6 big European countries: Germany, Greece, Italy, Netherlands, Romania, Switzerland, and patients with lung infections meeting the sepsis 3 definitions, we randomize them per strategy of treatment. What does that mean? That means that the patients, they get standard of care according to the Surviving Sepsis Campaign. On top of that, if they suffer by macrophage activation syndrome, they get intravenous anakinra. If they suffer by immunoparalysis, recombinant interferon gamma. And those who are in the placebo arm, they receive placebo treatments. Which were the patients who were allowed to participate in the trial? Adults with lung infections or primary bloodstream infection, meeting the sepsis 3 definitions, with macrophage activation-like syndrome or immunoparalysis, and they started treatment the first 72 hours from sepsis onset. When it came to COVID-19, patients with secondary infections of COVID, they could be enrolled, and patients with active COVID-19, they could be enrolled only if they had a macrophage activation syndrome. We excluded patients with stage 4 malignancies, with neutropenia, with catheter-related infections, under chronic use of corticosteroids or chronic use of biologicals. And indeed, it was a very tough trial. It took place, as you see already, in 5 countries, and it was a very strenuous effect because you know very well that sepsis arrives usually late in the evening or late in the night, and we had transportations of samples from across Europe to our central lab here in Athens. Our endpoint was the improvement of organ dysfunction. And this was expressed as the change of the mean SOFA score on day 9. There was a huge list of secondary endpoints, of which the most important was 20-day mortality, restoration of immune dysfunction, and infection disposition at the end of treatment. The duration of treatment for all patients was 15 days. And also, we had post-hoc subgroup analysis. I don't want to read all these exhaustive lists because I will present you the data. Allow me first to acquaint you with how many patients were enrolled. So, as you may see, suffering from macrophage activation-like syndrome or suffering from immunoparalysis when you are septic is not uncommon. We had to screen 672 patients to enroll 281, meaning that almost 40% of the patients with sepsis, they were meeting our classification immune criteria and they could be enrolled in the trial. In total, 131 patients in the precision immunotherapy arm were the intent to treat population and 145 in the placebo arm. Allow me to walk you through the disease severity characteristics of these patients. The majority were male. They were around 70 years old. Their main comorbidities were cardiovascular, diabetes, coronary heart disease, chronic heart failure. Several of them, they were under COPD. The SOFA score they were suffering or were 10. Allow me here to stress that there was an impression that patients in the yellow arm of precision immunotherapy, they were a bit more severe than patients under placebo. The majority, they were under mechanical ventilation and vasopressors, and around 20%, they were under continuous venovenal filtration. The majority of our patients, they had lung infections. And the most common prescribed antibiotics were piperacillin azobactam, carbapenems, a lot of colistin, a lot of linezolid, a lot of glycopeptides. And based on the antibiotic susceptibility testing, almost 85% of our patients were receiving correct antibiotics. So the question comes, I showed you the characteristics of the patients. I showed you how these patients were treated. Allow me also to show you a bit their fundamental immunological characteristics. All of them were hypoxemic. They had increased lactate. They had increase of CRP, increase of procalcitonin, and also you see that the macrophage activation-like syndrome has a lot of ferritin, more than 4,000 nanograms per ml, most of our patients, contrary to patients with immunoparalysis. But the real question is, you know very well now, by looking at the table of demographics, that what I described to you are the patients of our everyday reality, which were around 70 years old. They are on mechanical ventilation and vasopressors, which gives them a SOFA of 10. They have a substantial risk of dying. And as a rule, we consider that all of them are the same, but not all of them are the same. Some of them, they are very huge ferritins, very high ferritins. Some others, they have very low HLA-DR, and functionally, they are different. And on top of their antibiotics, on top of their mechanical ventilation, on top of hydrocortisone replacement, they are in need to get precision immunotherapy. And look at the huge result. The improvement of organ function, which is achieved in 35.1% in the precision immunotherapy arm, contrary to 17.9% in the placebo arm, 2.5 times more improvement, which of course is statistically significant. And this is happening on day 9. And actually, it was really bizarre. JAMA, which is the journal where the data were published 1 month ago, they told us, we want to see that visually. We don't like just the mean SOFA score. What the mean SOFA score means, we want that you show to us in a visual way, day by day, for each of the patients, how was the change of the SOFA score. So what you see here, in the left panel is the placebo group. In the right panel is the precision immunotherapy group. Each one of the columns is one of the days of treatment. Treatment starts on day 1. And you see every row is one patient. And you may see how the SOFA scores, they change as we move from day 1 to day 9. The brighter are the cells, the better are the SOFA scores and the organ dysfunction is improved. The more dark they become, the more the SOFA score is increased, and there is no doubt that the patients who are with dark heat maps are those in the placebo group, much more in the precision immunotherapy group, whereas in the precision arm, you have many more rows, which they become enlightened, which means that the patients, they were improved. We have been asked even to do a multivariate analysis and take into consideration the baseline scores of severity, a patch, Johnson's comorbidity index, the SOFA score. One of the reviewers said, we want that you do separate analysis, taking into consideration the sites which enrolled many patients. And even under these conditions, precision immunotherapy, even in the light of the Apache score, the comorbidities, the SOFA score, delivers much more improvement of organ function compared to the rest of the patients. And then the question comes, okay, by day 9, everything is okay, but the treatment lasted for 50 days. Or someone could say, it's not only that, you give 2 separate treatments. You give anakinra to patients with macrophage activation-like syndrome. You give recombinant interferon gamma to patients with immunoparalysis. Do both patients with macrophage activation syndrome and immunoparalysis receive the same benefit, or benefit is coming from one of the 2 drugs which you use? And here you see that the benefit is even in both groups. What counts as precision? And from the moment you recognize precision, you may improve the outcome of the patients. But if we load at later time point, day 15, when treatments stopped, at the end of treatment, improvement sustains. How about mortality? Mortality was lower in the group of precision immunotherapy. How much lower? 6%, which you know very well that for the guidelines is considered a substantial benefit for our patients. However, by day 90, this benefit is lost, and this drives thoughts whether we need to repeat treatment for patients who are staying longer in our ICUs. But what is really important is not just to know what is the clinical benefit. What was needed in the trial was also to demonstrate that by delivering anakinra in patients with macrophage activation, ferritin went down, that by delivering recombinant interferon gamma, HLA-TR went up. And these are the time to event curves. And by day 0, there is no restoration of immune dysfunction, but as the curves, they move upper right, the more rapid restoration of immune function comes, and this ends up to almost 80% of patients under precision immunotherapy compared to only 48.5% of patients of the placebo group. And finally, on day 15, end of treatment, the investigators were asked, how did you see the outcome of your patients? Was infection resolved? Yes, it was resolved in 44.3% of the patients of precision immunotherapy compared to 31.7% of placebo. Intermediate, not much of a difference. Failure, less failures in the precision immunotherapy arm, and less superinfections. Why less superinfection? Because with that approach, the immune system stays healthy and there is no risk for secondary infections. But allow me also to do some subgroup analysis. And subgroup analysis led us to focus on 2 main things: the SOFA score at a cutoff of 10 and the Johnson's comorbidity index at a cutoff of 5. And you see there that the odds ratios show much more improvement when SOFA score is more than 10 and where Johnson's comorbidity index is more than 5. But if you look at mortality in these subgroups of patients, patients with lower Apache, patients with higher SOFA, and patients with higher comorbidities are the patients which they live more and longer. And someone could say, but you have an impact on the immune function. Can this effect on the immune function decreases the resistance of the patient to infection? And are the patients at risk of serious emergent adverse events? As a matter of fact, we had, as it's happening in a trial of critical care medicine, several reporting of serious adverse events, but few were probably or possibly related to the study drug, showing that the drug treatment was not risky. In conclusions, we ended up that the primary endpoint of improvement of organ dysfunction by day 9 was met 2.4 times more in the precision arm compared to the placebo arm. But the idea of the secondary endpoints is that the secondary endpoints are important improvements of the clinical state of a patient if they are driven by the primary endpoint. And indeed, we managed to demonstrate that even if you have hyperinflammation, you get improvement by anakinra. If you have immunoparalysis, you get improvement by immukin. This is extended by day 15. There is a decrease of 20-day mortality, no effect on 90-day mortality, improvement of immune function, and also better infection disposition by day 15. The question is, do we stay here? And actually, I'm pretty glad that Professor Emine Alp Meşe, she's with us, and she is my chairman for today, because this is actually what we want to build with all of you in the years to come. Now we have recognized that among patients who are unclassified from the immune, in terms of immune function, we managed to classify 20% of them. They are those who are presented here in red. They have a endotype which is driven by interferon gamma. And recently, we have finished a phase 2A trial in Greece, and it has been already announced that this trial improved the outcome of patients with sepsis driven by interferon gamma by delivering them adjunctive treatment with a monoclonal called emapalumab, which blocks interferon gamma. With that, we want to move along to a pivotal registration trial of this drug, and we are looking forward to the collaboration with study sites and ICU study sites from Ankara and from Istanbul. And we want to enroll patients with all types of infections, using our lab in Athens as the central lab in exactly the same way as we did that for Immunosep, where we not just use the biomarkers to identify the correct patient to treat, but also to measure biomarkers over days of treatment and to decide when to stop treatment. The vision of Immunosep was not just mine. Behind Atea is a close friend. We were fellows together more than 2 decades ago in the Netherlands when we were young and optimistic in life. And I am glad and happy that we managed to keep this smilish optimism over the years and to end up with the results of Immunosep. This is our consortium across Europe, and what we want is that this vision is broadened, and we're looking forward to the collaboration with you in the new trial, the EMBRACE2 trial for the registration of emapalumab in the year to come. Thank you very much for your attention, and I'm looking forward to the discussion.
Thank you very much, dear Evangelos. It was an excellent presentation, really. It was very good for me. I would look for the questions. There is one question. Are these all patients all in critical care units? One of our one person said.
Well, yes, so the patients who were enrolled in the Immunosep trial, yes, they were in the ICUs, and also the patients who participate in the trial of emapalumab, they were in the ICUs. But we recognize very well, because I presume that you're facing in your country exactly the same problem which we face in Greece, that we don't have enough ICU beds, but we have many critical patients who stay outside the ICU. So the answer is that yes, treatment can be delivered even outside the ICU.
Thank you. And also he thanked to you. There is no other questions I see here, but if you want to ask anything, Emine Hocam.
Yeah, thank you very much for this excellent talk. I'm very excited about the results. Thank you so much. Do you think that earlier phenotyping, maybe within the first 24 hours, could amplify better clinical outcomes for these patients? Earlier immunophenotyping, do you think that? Because here you have improvements, you had improvement in SOFA scores, but the mortality rates are not significantly different between placebo and immunotherapy. If we have earlier administration of this precision immunotherapy, do you think that we will have a better results? Maybe in
Well,
24
this can
hours?
only be a hypothesis and it remains to show that. But, this 6% difference in mortality, which we had at Immunosat, it could not be statistically significant just because the number of the patients which they got treatment was limited. Actually, if we had 300 patients per group, then that 6% difference would have been statistically significant. The limitation there is that this was a trial which was funded by the EU. It was not funded by the industry, and it was impossible to have enough financial support to enroll the number of patients which were needed for a trial with an endpoint of mortality. Now that we know that there was that 6% difference in mortality, what we want to move along is to receive advice by the European regulatory on what is needed for the next step.
Okay. Thank you. I have two questions from the listeners. One is asking about adresizumab. He's asking about what about adresizumab?
Well, adresizumab is a monoclonal which actually they even changed their name now to ebaparsimab. And this is manufactured by a German biotech called Adrenomed. As far as I know, they have run a promising phase 2 trial whereby using a biomarker, bio-ADM, they decide who patient to treat and who not to treat. The idea is that the monoclonal binds to adrenomedulin and does not allow adrenomedulin to leave the vessels, and with that way it restores the integrity of the vascular endothelium. What I have listened the last 2 or 3 years is that this company, they were wishing to move along with the phase 3 trial, but I haven't seen this trial starting yet.
Okay. And another question about hydrocortisone for adjunctive therapy after immune phenotyping.
Well, the vast majority of our patients, they were on hydrocortisone. Many of our patients, they were receiving dexamethasone. Some of our patients were on methylprednisolone. All in all, around 65% of our patients were on corticosteroids. So we ran an analysis to see if there is an interaction between immunotherapy and corticosteroids, and also whether the benefit has to do with the use of corticosteroids or not. We could not find any signal that there was a synergism between corticosteroids and immunotherapy.
Okay, thank you. There is another question about the place of renal replacement therapy for sepsis.
Well, I believe that probably what the audience wishes to ask is this type of hemodialysis, which actually they are filters which they absorb inflammatory mediators like cytokines or endotoxins. Actually, there are three of them out there. I am familiar with two of them. One is called FRNLPS, the other is the cytosorbs. And the real problem these devices they're facing is that they have been tested in few patients and not large randomized trials exist. All what exists are prospective treatments of few patients without any comparator arm. And this is why the Surviving Sepsis Campaign guidelines, they do not make any recommendations either against or in favor of them. So I believe that much more study is required.
Okay, thank you. I would like to ask something before the two questions. What do you think about the timing of anakinra? When should we give it? Because sepsis is a very dynamic process. The timing must be important. When did you give? When do we have to give it?
So actually, all our patients, they were treated at around 48 hours from onset of sepsis. I don't know if this is correct or not. All I can tell you is what our statistics are telling. In other terms, what is the median delay between sepsis onset and start of treatment, which was 48 hours for our patients.
Okay, thank you. There is a question about noradrenaline and dobutamine for hypovolemia.
Well, actually, this has to do with the current guidelines. The guidelines, they suggest that in order to start vasopressors, you need to be certain that the intravascular volume is restored and also that lactate is increased. So, but of course, there are many cases where you need to start vasopressors just because the patient is on the ventilator. He cannot stabilize mean arterial pressure. So with that in mind, everything is fully individualized. As a rule, I prefer and I stick to the guidelines on noradrenaline. On dobutamine, I need to be, I rely of what my heart echo will suggest.
Okay, thank you very much. There's a question. Is there a group taking only cortisone? Is there a group at your study? If there is, how were the outcomes?
So, as I mentioned earlier, we did not see any superiority of giving corticosteroids in the placebo group versus the placebo patients not on corticosteroids. Of course, in order to see such a difference, because the effect of corticosteroids on mortality is roughly 2%, what you would need is to have thousands of patients. So this does not exist in our trial. And the trials which they favored the introduction of dexamethasone for COVID-19 or low hydrocortisone replacement for septic shock, they were trials which they enrolled 4,000 to 5,000 patients. So really, the benefit in terms of survival corticosteroids they bring is marginal. And another issue with corticosteroids is, particularly because a community-acquired pneumonia is a main driver for sepsis. There is this French study suggesting that if you have severe CAP, you need to receive hydrocortisone. And after that was published in the New England in December 2023. And then all of a sudden, the REMAP CAP comes 7 months ago. published in Intensive Care Medicine, where they describe that the chances that you introduce harm to your patient by giving him hydrocortisone are as high as 80%. And they suggest, again, hydrocortisone. So it is really a lot of ambiguity on corticosteroids. What I would suggest is that we need to follow the median path, as it's always when it comes to compromise things in life, and to give a low dose of hydrocortisone to replace the needs for a patient who's at septic shock.
Okay, thank you. This is another one. How was the outcomes on patient with bacteremia other than the ones which were excluded? Is there a difference between the diagnosis of the infection?
Well, originally we tried to see if primary bloodstream infections were making some difference, but we could not see a trend in terms of outcomes between patients with bloodstream infections and patients with lung infections.
Okay. Here's another one. Does the immunosep study foresee simpler and faster alternative biomarker combinations to improve the generalizability of this personalized algorithm in hospitals with especially limited technical capabilities?
So ferritin is a biomarker which is used worldwide. So when it comes to ferritin, this is relatively easy. The real technical issue, which we do acknowledge, is the HLA-DR, which requires flow cytometry. And when it comes to secondary hospitals, which they do not have which they do not have the technology to do so, the question is what you can do to replace that. So, as a matter of fact, it is widely acceptable that if the total absolute lymphocyte count is less than 800 per cubic millimeter, this could be used as a diagnostic of immunoparalysis.
Good. Here it comes. While there is a golden hour rule for antibiotics in sepsis management, this window is not yet clear for immunotherapy. Is the immunosep protocol, does the time window defined for initiating immunomodulatory agents better capture the early cytokine storm phase or the late immune exhaustion phase of sepsis?
So, what the immunosep is proving is that there is no early pro-inflammatory and late anti-inflammatory stage of sepsis. Actually, the real improvement and progression of knowledge immunosep is bringing is that what we know about all patients starting hyperinflammatory and then jumping to hypoinflammatory does not exist. It shows that patients either they start hyperinflammatory and they stay hyperinflammatory until the end, or they start hypoinflammatory and they stay at that until the end. In other terms, the traditional approach and the traditional knowledge is changing. And allow me to tell you something. What we know traditionally in medicine, we like to describe things. We like to say that, for instance, glucose turns into 1.6 phosphate glucose to enter the cells, and this is metabolizable through lactate. But how do we know that indeed the pathway of glycolysis exists, or the pathway of neoglycogenesis exists? Just because metformin can inhibit that. If there is no inhibitor, everything is theoretical. So the beauty of immunosep is that it teaches, now we know where hyperinflammation is, where hypoinflammation is, just because the inhibitors, they restored the immune dysregulation. So what we need to know is that we have to change our understanding about the time of inflammation. There is no start with hyper and then jump into hypo. Either you are hyper from the very beginning or you are hypo from the very beginning.
Okay, very good. Actually, we talked before, you said 48 hours, the optimal timing of the therapy. If we
No,
use...
no. It does not mean that because we gave treatment, we managed to deliver treatment the first 48 hours, that this is the optimum. We just said that with the settings which we used and the abilities, we managed to give treatment the first 48 hours. But please don't consider that this is optimal.
Okay.
We said that that was feasible. It is
Feasible.
always the distinction about what is wishable and what is feasible. Of course, we would wish to give the best treatment to all our patients at 0 time. But
Of
is
course.
this feasible?
Okay. If we give it late, for example, refractory septic shock patients, can they have some effect from anakinra, or is it a late time for anakinra for patients?
The advantage of the biomarkers, and this is what you may recall at the beginning of my talk, I tried a bit theatrical to say that, look at what we are doing in our clinical practice. We don't follow what the evidence is telling. We follow what our prejudice is suggesting. For instance, we say, this is late. Why this is late? Just because we want to consider this late. What is early? Just because we consider this is early. But there is no definition what is early or what is late. For instance, I like to say to my medical students, all of you have the reaction that in cold, you should be well dressed just because when you were young, your mother was telling you have to be well dressed because you will get pneumonia. But we know that you get pneumonia in winter because we are all together and we are overcrowded in exactly the same way. If the biomarker is increased, the pathway is there, and you don't care if it's early or late or whatever. You treat a pathway, irrespective when you measure that the pathway is activated.
Okay. Very good. Perfect. Thank you. I think, one more. But we strongly believe that after phenotyping, we can easily use steroids if the patient in hyperinflammatory state. I didn't understand it.
Well, it may well be the case that the question coming from the audience is whether a high glucocorticosteroid treatment may improve the outcome of the patient. The answer to this is that dexamethasone is licensed only for severe COVID-19. But severe COVID-19 is one thing, and what we used to call in the past severe sepsis and septic shock is something completely different. So our data, they say that we need to follow the strategies which we are following until now for corticosteroids. Corticosteroids cannot replace precision immunotherapy. Precision immunotherapy is something which should be given on top of corticosteroids.
Okay, not instead. Okay, what do you think about the role of machine learning in septic shock care?
Well, this is a real difficult question. And, actually, when it comes to the question of machine learning and artificial intelligence, you know that when you have plenty of people speaking about something, the reality is that nobody knows what this is exactly about. So, what we have in mind about artificial intelligence and machine learning and artificial intelligence are separate things. Machine learning is a type of artificial intelligence, but the vice versa does not exist. For instance, what is happening when we complete, let's say we have an app, and the app in our mobile tells, please complete the values of hemoglobin, white blood cells, CRP, and then press enter. And this tells you what may happen to your patient. This is machine learning. What is artificial intelligence? That YouTube, which is following up, always in our mobile, brings to us videos and figures which we have been in the past. So in other terms, it was trained with our habits. This means that in order to train artificial intelligence as a physician, we need to find a way to bring in the system all our experience of the past. So tell me, is there a way, I mean, all of us who are here in this session, we bring all together, each of us, at least 30 years of medical experience. How easy is to bring 30 years of medical experience, but look, not only the experience, but also what we are doing today. Is it similar to what we were doing for our patients 20 years ago? No. First of all, because there was a lot of evidence that we have to change what we are doing. Second, because new drugs came. And third, because our approach of the matters has considerably changed. The last thing is something which so far is impossible to deliver to a machine, the feeling of the matters. So I believe that we need to try to train artificial intelligence. I'm positive in this, but in a type of 2 dimensions of how practices have evolved over the acquired knowledge, and then what AI is delivering to us needs to be enriched by us humans about our feelings of things. So AI should become our tool and can never substitute us.
Yeah. Yeah, thank you. I think this is the last one. In patient with refractory septic shock characterized by predominant cardiovascular collapse and requiring higher dose vasopressors, what are your thoughts on anakinra's endothelial protective effect and its potential role in microcirculation? Could adding it to standard steroid therapy create a synergistic effect?
Well, as I told you, our analysis did not show any evidence of synergistic effect. Anakinra does not have any effect on vascular integrity. All the effect has to do on the decrease of IL-1. So if there is an effect on vascular integrity, this is indirect through the downregulation of inflammatory mediators.
Okay. Thank you. I think that's all for the questions. Thank you very much. Do you have anything to say, Dr. Emine?
Thank you very much, Evangelos. It's our great privilege and honor to host you today. It's really appreciated. Thank you so much, and hope to see you and hope to have a collaboration in the future with you about the immunotherapy. We are very happy about this. Thank you.
I do.
And
Thank you very much.
Also, we are also open to collaborations in our city, not only Istanbul and Adana, Ankara. We also want to collaborate
That will
with
be great, and I'm really much looking forward that we start a sustained collaboration. Thank you so much for your hospitality. Thank you for your kind words. Thank you for having me, and I'm looking forward of that. This is just the beginning of a really important collaboration. Thank you so much.
Thank you very much.
Have a great evening. Bye.
Herkese görüşmek üzere. Hoşça kalın.